Hi, and welcome to today's episode of JAMA Network Open Live. We're here to talk about 3 articles from this week's release of JAMA Network Open. Of course, if you're following along live, please comment, add questions, say what you will on Twitter, Facebook, or on YouTube. You can comment right below the videos or mention us on Twitter at JAMA Network Open or hashtag JNO Live.
We're back as usual. I'm Mike Berkowitz, electronic editor of JAMA and the JAMA Network, joining Seth for a conversation about the most interesting articles in the most recent release.
Well, yeah, I didn't say who I was. I'm Seth Truger, digital media editor for JAMA Network Open.
He's still Seth Truger.
Still, for now.
And we'll talk about some other things, but let's dig into the articles first. What's up?
Right. So we'll go right into the first article. So factors associated with acute pain estimation, postoperative pain resolution, opioid cessation, and recovery. Secondary analysis of a randomized clinical trial by Jennifer Ha and colleagues.
Great. And as a general internist, as you know, kind of geek, I'm always interested in perioperative care and consultation because internists are called all the time onto surgical wards to say kind of how to manage things. Now, surgeons know how to manage pain, and they're getting I think, more sophisticated about managing opioids in the face of the opioid epidemic. But what are they trying to do here?
Right. So this paper, like I said, is a secondary analysis of a prior RCT. That RCT was testing gabapentin for post-op pain. It was randomized against an active placebo or active control, which was a little odd to me. It's lorazepam or Ativan, which...
Right. Well, one is an analgesic and one is a sedative.
Right.
So, you know...
But, yeah. My take on benzos for acute symptoms is generally whatever the patient's complaint is, there will be less of it if you give them benzos.
I think you're accurate. And that was published in JAMA Surgery. That's a JAMA Network trial. So this is a follow-up.
Right.
And
sorry. Always good to see surgical RCTs. So this is a follow-up, a secondary analysis, where they tried to see what features of the patient's reported pain in the first 10 days postoperatively kind of correlated with their longer-term pain resolution. They used some really interesting, what I thought were really rigorous outcome measures. They basically they asked them about pain every day in the hospital till post-op day 10. Then they called them, at home every day until the pain was every day for a few months, and then every week for a few months, and then every month for a few months, basically until they had 5 times in a row where they said they had no pain anymore. The patient said that they recovered from surgery, and the patient wasn't taking opioids anymore. So when they said the patients were recovered, the patients were recovered.
For real. So this is an observational study. They've converted the RCT into kind of a long-term observational study. I don't know whether you've heard the old saw that all randomized trials are observational studies by 24 hours because things begin to happen, there's crossovers and so on. But this is a true kind of pooling of people in both intervention arms to see what kinds of pain scores and clinical characteristics are associated with recovery and resolution of those pain.
Right. In addition to the different time points I mentioned, they also asked different things. What is your current pain level? What has your average pain level been? And what is the worst pain you've had in the last 24 hours?
Okay.
And basically what they found is from all those different measurements in the first 10 days post-op, they found that the worst pain reported in the last 24 hours at the post-operative site was the one that correlated the most with whether or not the patients either had worse pain or better pain resolution longer term.
So that was the worst pain score at post-op day 10,
correct,
right? Was associated with whether they felt better in the longer-term follow-up.
Right. So patients with the least amount of worst pain in the last 24 hours.
Yes.
So of the worst pain in the last day, people with the lowest pain were most likely to have a shorter course or a better course of postoperative pain.
Is that surprising?
Not really. I mean, one thing that's interesting to me here is, from what little I know about pain reporting, I think what's been in I don't know, totally blanking. Malcolm Gladwell books, New Yorker articles.
Right.
I heard Rob Golub from JAMA mention this too, so I imagine there's some science behind it. But like when a patient has a painful procedure, the 2 things that correlate the most are the patient's memory of the experience of the pain, is the worst pain and the last pain. So these seem like pretty reasonable outcome measures. And the worst pain in the last day correlating seems to make sense.
Right.
What do you think?
So I have a lot of thoughts. One is that Zeke Emanuel wrote this interesting New York Times op-ed piece talking about how kind of that final measure, whatever it is, whether it's home renovations or colonoscopies, that final experience is the one that determines your memory of how it goes. So if you get good drugs at a colonoscopy, it's painless. And if your home general contractor ends up finishing up the job correctly, you end up feeling really good about the job no matter how painful it was.
Right.
So at some level, there's a general principle at play here. I'm not representing Zeke as well as he does, obviously, but do a search for New York Times Zeke manual and colonoscopy, and you'll see that op-ed. Yeah. My response to this is partly kind of, you talked about all these pain measures. They measured a lot of stuff here, and this seemed less like a fishing expedition than an ocean trawling expedition, in the sense that they threw the kitchen sink and the plumbing of the entire house at this question and kind of came up with these results, which seemed pretty intuitive, which is the sense that after 10 days after your operation, if you're kind of feeling better, you're more likely to be feeling better in the long term. And if you were feeling worse, you were more likely to be feeling worse in the long term. So I'm not quite sure where this moved us. Do you know who Alvin Feinstein is?
I don't.
Alvin Feinstein is kind of the father of modern clinical epidemiology. Well before evidence-based medicine in the 1960s, he was kind of putting mathematical principles into clinical research. He wrote this book called Clinical Judgment, which I brought here. It's still a classic, and I recommend it to anybody. It holds up. I'm not sure if it's available commercially. I'm sure it's out of print, but you can find it in free versions online. And in any event, he used to say, torture the data until they confess. And I kind of believe that that's kind of what happened here. With all of these measures, there's like 15 different measures. There's data mining. There's lots of stepwise and backward regression fitting and so on. This was going to yield something. So it's useful evidence, but I'm not sure it moves us forward clinically.
Right. I mean, I think I'll take the first three words from the statistical analysis section of the paper is data mining algorithms were applied.
Right.
And they looked at a lot of data. I think a positive thing I could say about that is they didn't find surprises. So even if it reinforced our priors, this doesn't mean it's necessarily bad.
Right.
And also, if you look at the figure 1, this is just one part of figure 1. There's a couple different graphs, but they also tried splitting the patients up into high pain and low pain clusters to see kind of where people grouped. And by a couple of the measures, the patients seemed to group where some people had more pain and some people had less pain. It was pretty consistent.
Right.
It's not totally true, and I think it was the average pain one might have been more mixed than this one shows. But again, I think to your point, just the people with the least pain in the short term at the end of their kind of week and a half of recovery, where the people had the least pain later on, isn't terribly surprising.
Okay.
But they also made 19,000 phone calls to postoperative patients.
And they said, enough already, leave me alone, I'm feeling better.
Right. I would have to, I had to do that 5 times. You got them to stop calling.
5 times in a row.
Yeah.
Right.
Some of the other things that came out that were a little interesting, some of the risk factors they found for more likely to have longer or worse pain postoperatively were unfortunately women, patients who had pain before the operation at their operative site, at their surgical site, and also, not surprisingly, but sadly, patients with prior alcohol or drug abuse treatments, which there's probably some level of either they're wired that way in the first place, or they've, I'm totally blanking on words. They build up a tolerance to pain medications, or just more likely to have pain, and that's maybe why they have substance abuse issues.
Got it. So before our viewers start fleeing in pain from listening to this overly long conversation, I just want to, we're close enough now, we've been sharing some pet peeves, and I have some editorial pet peeves, and one of them appears in this paper, which is that the authors call this measure of pain at post-op day 10 a predictor of recovery. And prediction is really methodologically quite a different thing than a multivariable regression where you find an association. There's actually a recent reporting methods and research reporting guideline called Tripod, which talks about what you need to designate a variable as a good prognostic variable. And I encourage anybody who's interested in these methods issues to go to equatornetwork.org. Just do a search for it and look for the Tripod reporting guideline, and that'll tell you what you need to do if you're going to claim that you're looking to predict something rather than kind of just find an association.
Yeah, and a bit of a shameless plug, one thing I found when I got onboarded here was on the JAMA Network Open instruction for authors page that tells you what type of papers to do, how to format things, etc. Each paper type has the recommendation for what guidelines to use for different types of reporting. It's just a really good general resource.
Right, and I'm going to kind of see you that and raise it one, which is to say that it's not only the guideline that's interesting, but each of them have backup elaboration and explanation documents, and they are contemporary, basically chapters in clinical research that are incredibly practical and written by the leaders in the field. Dave Mower in Canada, and all names, Jan van den Broek in the Netherlands, all sorts of people who are really defining what it means to conduct clinical research, write these background documents, and I encourage anybody who's interested in clinical research to look at those and not just the reporting guidelines themselves.
All right. Well, there we go. Well, let's move on to the next paper.
Okay.
Here, next we have the comparative accuracy of diagnosis by collective intelligence of multiple physicians versus individual physicians by Michael Barnett and colleagues.
Michael Barnett. So collective intelligence, is this the Borg?
Pretty much, yeah.
Okay. Resistance is futile.
Except a kind of farcical version of it. This is actually the same app we talked about, the Human Diagnosis or Human DX app we talked about back on January 14th, where they did a paper. It was basically just looking at, are attendings more accurate than residents, more accurate than medical students in these app-based physician diagnosis cases?
Yeah, so this, you know, my defenses are weakening. I mean, this is kind of getting interesting now that I'm looking at a second paper. This is kind of like a diagnosis lab in a way, where they can report on this area that's crucial to clinical medicine, but that not many people are thinking about. We're so focused on therapy and management and maybe even prevention, but this is about kind of getting to the answer, and they're kind of building up this resource that allows them to try and apply a scientific lens to this process.
Right, and I think the fact that they're using this data for good right now seems really good.
Right, rather than for evil.
Right.
Okay.
And, right now. And again, just to review, this is basically an app or web-based program where you sign up for it, and every day there's cases you can do. You get a bit of the HPI, then you can click on more data, physical exam data, vital signs, lab results, et cetera, and then you construct your list of your differential diagnosis. One of the shortcomings of this is that's not how we make diagnoses. I walk into a room, I get a million data points that I don't even consciously process. Like when I see a kid with a cough, 99% of my work is probably done subconsciously before I even ask the kid a question or anybody opens their mouth or throat or listen to anything, and it's not individual points of data on a screen.
Right. Okay.
But it's interesting. So what they did is they just took the cases they had. They didn't do new stuff with the actual docs who were doing the cases, and then they basically looked at if you did different combinations of more than one physician solving the cases, were you more likely to get a correct answer? And if you look at Figure 1, you'll see the answer is yes, you do. As you get more physicians, differential diagnoses on board, and they do different types of weighting to see how, if it's first in your differential versus second in my differential, then it was weighted differently. But basically, yes, you get asymptotically more accurate each time with each additional physician up to 9.
So one thing I wasn't clear on is the January article we discussed, those were simulated cases. Are these simulated cases too for the purposes of the research, or are these real ones that were up there?
No, I think these are the same ones in the app.
The same ones. Okay.
Yep.
So that's good to know. A second thing, and you may not be able to answer this, is that, there's lots of times where people would come up with different differentials or problem lists for the same patient, which are kind of equally accurate but look different. So if I have, and I'm going to come up because I'm an internist with a zebra, like amyloid cardiomyopathy, you could say heart failure, or you could say systemic amyloidosis, and both of those could belong on a differential. But I think this favored the highest rated differential.
Right.
So your number 1 differential diagnosis was weighted 1, your number 2 was rated half, your number 3 was weighted third, and so on. But they could be equally correct, even though. Do you know how they manage that methodologically?
So here, I believe what they did is you make your differential list in the app, and they do. I think it's the main one was 1 over n. So if you put pneumonia first, that gets full credit or full weighting, and if you put heart failure second, that's 1 over 2. So there's 50% weighting. If you put COPD exacerbation next, then that's 1 over 3, and that's how those got weighted.
Okay.
And also, I think, and this is something not specific to this study in general, or specifically, but in general, trying to assess physician accuracy is really tough because we don't do things like on the board exam where you take a history, you take a physical, you do labs, you construct a differential, and then you do one treatment. We do lots of things in parallel at the same time.
Right.
When I have a patient in respiratory distress, they usually get some combination of 7 nurses and techs getting IVs on them, somebody throwing BiPAP on them, listening to lungs, ultrasound in various places, multiple simultaneous therapies that are working working at different parts in the differential that may be weighted differently, and also some things that, more likely, what's the right mistake to make? Should I treat that? Probably not cellulitis, but 40% chance it is, because if I don't treat it and you're septic, then you're more likely to die, even though it's probably going to end up being stasis dermatitis.
Right. The other aspect of this that I reacted to is it's intuitive. We all try and ask colleagues, hey, can you come and look at this and kind of give me some help when it's not obvious, when things aren't kind of clicking. But you want to spend that resource wisely, right? So there's lots of diagnoses that are either clear or that you're confident enough that you have a handle around. And I'm not clear what the spectrum of cases were here, whether they're asking 9 physicians versus 2 physicians or versus 1 physician for easy diagnoses or for difficult, complicated diagnoses and so on.
Well, the accuracy rate was only for individuals only about 65%, so I imagine these are pretty tough cases.
Right. These are the more complicated ones.
Right.
And then there's other aspects of diagnosis. We published something in JAMA, an editorial a viewpoint that just came out last week, in our February 26th issue by Ashley Meyer and Hardeep Singh from Baylor College. And it was all about how to improve diagnosis. And I'm going to take the liberty of reading from it because it's very relevant to this paper. Because they say achieving diagnostic excellence requires focusing on not just accuracy, which is the paper that we're talking about, but also on minimizing costs, enhancing timeliness, and enhancing patient-centeredness. We want to be the clinician who makes the diagnosis using the fewest resources while improving patient experience and also managing diagnostic uncertainty and communicating that uncertainty and being willing to wait with patients in that uncertainty, saying, I don't know what you have, but I'll help you work through it, instead of just ordering lots of tests to satisfy them or yourself and kind of get away with uncertainty, instead of spending resources. So there's all those other aspects, and this focuses on just this one part.
Yeah, and that's I haven't read this yet. I'm going to have to now. But that really well, not right now.
I donate it to you.
We're going to take a pause.
No, we're not.
No, but I've been on a kick in the last little bit about trying to do better about communicating uncertainty with my patients. And I've really been having a lot of professional satisfaction with it. Like, for instance, one of the ways I've really enjoyed it is with a patient with abdominal pain who's not getting a CT or not getting workup for appendicitis, translating to the patient, look, like this is what I think. There's a good chance I'm wrong. It's possible this is early and you just don't have the signs yet. But we're going to talk about what to look out for. If you get worse, come back.
Right.
But the way I think about it is, there's maybe a 30% chance I'm wrong, 25% chance I'm wrong. If I keep you here and do tests, that's a 100% chance that you're here getting tests done.
Right.
And it's certainly, at least on the ground level, patients seem to appreciate it, and it seems to be working out okay for me. And again, I've been very satisfied with it.
That kind of makes you a superhero because in your emergency emergency department setting, it's the pressure's on for you to do something and for you to kind of define, or at least given the med-mal climate, kind of rule out for certainty all the worst things.
Yeah.
So I applaud that. In the primary care setting, I agree. I mean, patients seem to really gravitate towards those docs who take the time to explain the uncertainty and say, I'm going to be with you and help you work through it. And it may be time is the additional diagnostic test that we need to figure out what's going on.
Yep. Yep.
And some patients don't like that and leave, but the ones who really do stick with you.
Right. And I really think we, as physicians, we have lots of incentives to overtest and overtreat. And I think a lot of times we do that as a shortcut. Things like antibiotics for URIs, opioid prescriptions, borderline imaging tests like we're talking about. And we think this is what the patient wants, or it's an easy way to get to what's their 4th or 5th priority, when really if we sat down and talked to the patient, explain what we think and what's going on back and forth, and the patient feels heard, they know what to look out for, they feel reassured, expectations are set, they know they have a doctor who cares about them and is thinking about them, tends to be better than just, oh, they give me a Z-Pak, I'm happy with a Z-Pak.
Right. Sounds great. And I'm going to put in another plug for Alvin's book, Clinical Judgment, 1967. It was the summer of love, the summer of pepper, and he was writing about the application of mathematical principles to clinical diagnosis.
Well, as an ER doc, I'm going to stick with a 2-pager here before that, although I think that lives in my office.
Okay.
Technically. All right, so on to the third paper.
Yep.
Third paper, so Association of Long-Term Use of Low-Dose Aspirin as Chemoprevention with Risk of Lung Cancer by Shinhee Yi and colleagues, and again, apologies if I'm mispronouncing the name.
And you don't know this, but I love these aspirin papers because it just appeals to my sense of this low-cost historical drug that like may be doing things for us.
It's made from willow bark.
Yeah, willow bark, exactly. So it's kind of all, borderline natural, and it's been around. So tell me what this is.
Right. First, I'm going to say hi, Min. Thanks for the shout out there.
Oh, Min's here?
Yeah, Min's always says hi,
Hey,
which is
Min.
great.
Yeah. Thanks for joining.
So this is a great database study from Korea where they looked at 63,000 patients. No, sorry. Was it? They looked at everybody in a big database in the Korean National Health Information Database from 2002 to 2015. There were 13 million eligible participants.
Okay.
Of whom...
So let me just tell you, and let me tell the audience, I hear that and I think statistically significant, because when you get massive stratospheric numbers like that, any tiny difference is going to be statistically significant.
Right. Type 1 error.
Type 1, right. Yeah. But go on.
Right, which we can talk about if you want, but we shouldn't.
Yeah.
And they found that 63,000 of those 13 million went on to develop lung cancer. And they looked back to see who had gotten daily low-dose aspirin. So they define low dose the same way we do in cardiovascular disease, which is interestingly less than 100 milligrams. Apparently there's 100 milligram tabs in Europe. Even though we're used to the 81s here, that's, when you look at it, what counts as low dose. And found that if you look at Figure 3, patients who, there's definitely a dose response here, and that patients who had low dose aspirin, which they counted as more than two doses a week or more, for more than 5 years, went on to have less lung cancer.
So I'm going to geek out on you for a
Please
second.
do.
So they call this a cohort study, but the way you described it, it sounds like a case control, that they index patients by lung cancer or not, and then kind of look back to see the exposure variables that are associated. Is that... But it's not really case control because they're not looking at a very wide range.
No, because they started they started in 2002 with 13 million who were enrolled, and then some of them went on to get cancer. So I think it's fair to call it case.
Okay, because they're looking, because they're starting. They start time wise with the exposure variable, which is aspirin, not cancer, and they're not looking at lots of other things that could be associated with the lung cancer. That's the difference between case control and cohort in this instance.
Yeah, the way I try to think about it, and this stuff is hard, including having an MPH and studying some epidemiology, not as much as you, is a case control study is I have a group of patients who have a problem.
Right.
I now want to find a similar group of patients who don't have a problem and see what's different about those patients other than the problem.
Right.
Whereas a cohort study is I have a group of people, some of them go on to develop the disease. What's the difference between those and the people who didn't?
That's right. And to put it in other words, I think of you index by cases and then look at exposures, and in a cohort you look at exposures and you try and find the cases.
Yeah, that too.
Okay.
Great. That could fit in a tweet.
That could be a tweet.
Right. So it's interesting. So I think it's really fascinating. If this stuff holds up, and I don't think this is the only piece that's shown some sort of relationship here, then this is the kind of thing where if aspirin's relatively safe, I mean, I'm an ER doc. I see aspirin head injuries. Makes me, I don't want to put it in the water quite yet. If there's good reason.
Meaning people who are on aspirin who hit their heads and therefore are at a greater risk of a bleed.
Yep.
Got it.
Yeah. But again, that's my
your lens or your
my
frame.
bias at work, and I understand that I don't see people who don't fall and hit their heads as much.
Okay.
And also, there's other good uses for aspirin, like cardiovascular disease prevention. If it also happens to reduce lung cancer, that seems like it might be good. So I think this certainly seems like an area ripe for further study.
Right. And one of the questions we were talking about just before we went live is, so they have this massive database and they're looking at lung cancer. But last I heard, I don't think lung cancer is the only cancer in the world. So I wasn't sure why we didn't get a paper with broader a range of cancers. In 2016, JAMA Oncology published just such a paper from Andrew Chan's group at Harvard, looking at using nurses' health study and health professional follow-up study data. Those are all kind of food frequency and other kinds of questionnaires looking at these exposures and then kind of self-reported outcomes. And they reported on this range of cancers, and interestingly, lung cancer was not part of that database finding in that 2016 study.
Right. I
will follow up and say in 2018, not that long ago, kind of in November or December, JAMA Oncology also published papers showing an association from the same kind of data set, showing association between aspirin and reduced risk of ovarian cancer and hepatocellular cancer. So I find it all kind of tantalizing. It's because it's so dirt cheap and it's kind of available. And if we can give a chemopreventive drug, why not?
Right.
The reason why not is what you explained, is that there's risk. There's nosebleeds, there's minor bleeding, there's major hemorrhages, and so on.
Right. And, you know, to your point before, where I have a lot of incentives to overtreat and overdiagnose and overscan patients and things like that, scientists have reasons to split up their papers. There's lots of incentives to publish 7 papers on different types of cancer and aspirin prevention.
There you go.
And, you know, it increases your chance of getting talked about on JNO Live, if nothing else.
Right. And let me just close out this part of the conversation by saying I think the evidence is strongest, as I understand it, for colorectal cancer, particularly maybe with the BRCA mutation. And the U.S. Preventive Services Task Force, in their 2016 recommendation statement, which I think is the most recent one, gives a grade B recommendation for aspirin in adults ages 50 to 59 for prevention of colorectal cancer if they're willing to take it. If they have a life expectancy of at least 10 years and they're willing to take it for 10 years. So this is a long game. It's not a quick thing. But for those of you who are interested, consider aspirin. I'm not telling you to take it. Consult with your doctor or write Dr. Seth.
Right. Right. And I think for me, the most cynical thing, and I have very little data to support this, but as one of my professors at med school put it, basically, most of us end up dying of either cancer or heart disease. And
Right.
are these the patients who just didn't die of heart disease, and so they're on aspirin, and they then go on to not, or they're on aspirin because they have heart disease, and then they're more likely to get heart disease and cancer, so they end up dying of their heart disease first.
Right. And that's the competing risk kind of argument, which is always at play, and we're not that sophisticated in our methods as clinical researchers, as a community, of always integrating them into our models. They're pretty complicated.
Right.
What other things, you know, in observational studies, what other things could be accounting for kind of a selection bias or survival benefit for patients who make it into the study?
Right. And that's why good studies like this are hypothesis generating. We shouldn't change management based on an observational finding like this, but it seems reasonable, and now, you know, seems like good justification for somebody to fund a longer term research project that's prospective, randomized, and seeing if we randomize similar patients to get aspirin or not get aspirin, who's more likely to get cancer or not.
And because we haven't talked about it enough, I'm going to put a final cherry on top, which is to say the editorial accompanying those JAMA-ONC papers said that in the doses that people usually take them at 75 milligrams or so, it cannot be the anti-inflammatory properties. So the mechanism by which aspirin may be cancer preventive is still unclear, and bears also looking into, along with the clinical research, to understand why this may be having an effect and why it may be having an effect for some cancers and not others.
Right. Yeah, I read something in here about cyclooxygenase, and then I woke up later, and here we are.
Right. Okay.
Great. So I think that's it for these articles. Of course, go to JAMANetworkOpen.com and read these articles and more. They are, as always, open access and completely free to read. One thing we're going to add this week is we're going to review some of the other articles, just briefly, do some quick hits. So Mike, why don't you get us started?
So one of the papers that I enjoyed was one that used data from the National Lung Screening Trial that looked at added additional PLCO, prostate lung cancer, ovarian cancer trial data into a model that had been developed to predict lung cancer based on NLST data, and showed improved performance, improved risk prediction from CT scanning, which was the NLST intervention, to predict lung cancer. So it didn't actually provide, as I'm always looking for in these risk prediction studies, it didn't provide me a little index where I can add up little scores and find out what the probability is or what the likelihood is for patients. But that is always exciting to me, because the promise of lung cancer screening is yet unrealized for a number of reasons. A lot of false positives, a lot of people not taking it up, so anything that moves the science forward, I think, is useful. Right,
and also there's only so many CT scanners and only so many radiologists, so until AI takes over and does all those.
There you go. Don't tell that to the pathologists and radiologists, because they don't want to be unemployed.
Right. Actually, that brings me back. We forgot to mention the editorial, the invited commentary by Steve Finn, the deputy editor for JAMA Network Open, with a human DX paper, basically made the point, boiled it down to, we've got 2 great options on the horizon to improve our diagnostics, and that's AI and crowdsourcing. And the human DX project seems like making a good argument for some sort of crowdsourcing. And of course, we see lots of machine learning papers here. We called for them, in fact. So, so that's where I think some of the future might live.
Great. What else do we have in the issue?
Right. A couple other things in this issue, just to highlight effectiveness of implementing a collaborative chronic care model for clinicians on patient outcomes in mental health is an RCT where they looked at they'd taken a proven collaborative care model and implemented it in the VA and basically kind of did it as a pragmatic trial to see, does it improve outcomes, is it feasible, can people who aren't in a study do this kind of coordinated care? And they had pretty positive results, which is good. You mentioned that one. Another interesting database study from Sweden, from the Stockholm Youth Cohort, is they looked at patients' family history of mental and neurologic disorders and found that basically the more relatives you have up to 4th degree with either neurologic or psychiatric problems, the more likely a patient was to be diagnosed with autism.
Okay.
Which is interesting.
So any neurologic in autism?
There are more specifics about it, but it was things like depression, anxiety.
Yeah.
The usual things.
If you have a distant family history of mental health diagnosis, you are likely to have a future in an offspring diagnosis of mental health diagnosis.
No, and of autism specifically.
Autism specifically.
Yeah.
Okay.
And it's interesting, this Stockholm Youth Cohort, I dug into it a little bit a few months ago for one of our first visual abstracts for JAMA Network Open, and it's really interesting. I mean, these Scandinavian countries have these big, giant databases where they keep track of people for like decades and get this really good data on their health outcomes for years and years and years and get some really rigorous data. And then today I came across a cartoon online which is like, what if these Scandinavian countries are different? Like, oh, turns out if you separate twins at birth, they all like smoked fish.
Okay.
So that was my Clint Epi joke today. So
yes.
I enjoyed that.
And that's the run, that's the other important stuff?
Yep, that's the rundown for today.
Hey, and you know what? We've neglected to mention last week that 2 releases ago, Fred Rivera, who you met here at the end of the year, and Steve Finn, deputy editor, published a year in review. So my first question is, for you, Seth, I think we started publishing in May.
May 18th.
So is this a Venusian year? Because on Venus, the year is only 225 days, right? So it's not really a complete year.
Right. Well, it's the calendar year. It's the calendar year.
Oh, okay. The end of 2018.
Right.
Okay, great. So it was just a roundup of how many manuscripts we've received and kind of what's been most popular. And some of those popular articles may be of interest to a general readership because I think they were published before we started JNO Live. That's one was cardiorespiratory fitness and as measured by treadmill testing and mortality, and that showed no upper bound, I think, of fitness, if I remember correctly.
Right.
Another one was greening of vacant spaces in the metropolitan Philadelphia area and mental health measures, and it showed that taking these kind of trash-strewn, concrete, capped, vacant urban spaces and putting plants there helped people feel better. And then there was a third one, which I think, we've talked about these, about unapproved pharmaceutical ingredients in supplementary medicine. So, kind of Viagra and sex enhancers and statins and kind of things that are supposed to be good for your lipids.
Yeah, and in those little baggies you find it, like the bodegas, cash register stuff. It's just always really shady to me.
Right, so it's just kind of a look back on where we are, and we are full force forward in 2019 to see whether we can increase the number of papers we're publishing and the numbers that you're submitting. So if you're working on a paper, please submit it because we're on a roll.
Yep. We, a few months ago, got the official green light into PubMed, so everything's now listed indexed in PubMed.
Awesome.
Which is, not unexpected, but a very nice watershed moment.
Discoverability.
Yep. Always important stuff. And also, based on my quick back-of-the-envelope calculations, there have been 249 original investigations in JAMA Network Open in calendar year 2018.
Okay.
About 100 editorials and invited commentaries.
Okay.
And 11,000 citations to date. So this is not how you calculate an impact factor, but by my crude analysis, that would make the impact factor 30.
Where does the 11,000 come from? Is that Google Scholar?
I was in there.
It's
I just read in there.
An impact factor of 30.
Yeah.
OMG.
Yeah.
So don't take that to the bank, but maybe we're being a little aspirational, but we're off to a good start.
Right. Yeah. Certainly could be worse.
And let me say one other thing, and then we should probably close down, which is that a couple weeks ago, maybe 4 weeks ago, for those of you who may or may not have noticed, we started publishing our original investigations with Spanish and Chinese translations of our titles and our key points. The key points are kind of like a micro abstract. It's the questions, the findings, and the meaning. And if you or colleagues speak Spanish or Mandarin Chinese, you can now have access in your own language to our material.
And even if you don't, you can read them in Spanish or Chinese.
Yes, you can. Right. Indeed. And put them into Google Translate and see what comes out.
Right. So thanks for watching today. Of course, be sure to follow us on Twitter, Facebook, LinkedIn, and everywhere else at JAMA Network Open.
Yep. This was fun. Thanks for listening to us. Reminder that our new papers always come out on Friday mornings, 10 a.m. Central U.S. time, which is Greenwich Mean Time -6, no matter where you are in the world. So check us out then, JAMANetworkOpen.com. Follow us on Facebook, Twitter, or YouTube. You can subscribe to us there and sign up for our emails.
Of course, good stuff. Everyone likes a good email.
Okay. Thanks, everybody. Take care. Nice to talk to you.
Take care.